Hello everyone, this is Dr. Garima Sachdeva, and today we'll be discussing about the cervical cancer. We'll be discussing about the latest FIGO staging, stage-wise management, and the prognosis of CA cervix. So stay tuned, hope you find it useful.
Coming over to cervical cancer. So what are the risk factors? Most common is HPV, which contributes to 99.7% of the cases.
Okay.
And of these 16-18 HPV contribute to 70 to 80% of the cervical and anal cancer, and 40 to 50% of the vulval and oropharyngeal cancers.
Okay.
Other risk factors include smoking, OCPs. Risk is doubled in women who have taken the pill for at least 5 years, and the increased risk of cervical cancer begins to drop as soon as the pill is stopped, and the risk is same as background risk after 10 years.
Okay.
So OCP basically it decreases the risk of ovarian and endometrial cancer. For this cervical cancer, it increases the risk. So this you have to remember.
Okay.
I also told this in the
And
concept.
colorectal also.
Huh?
Colorectal cancer.
Protective against.
Yeah, it's cervical and colorectal.
Cervical and breast. Breast it is dicey. You do not give. It is category 4. Colorectal also it is protective. Okay.
Okay. Okay, ma'am.
Cervical and breast. Breast actually it is category 4 OCP. Cervical also category 4.
Okay. Ovarian cancer.
Protective.
So colorectal and ovarian protective.
And endometrial also protective.
Okay.
The increased risk of of clear cell adenocarcinoma of the cervix is seen in the females who took diethyldes during pregnancy, diethylstilbestrol during pregnancy. And family history of cervical cancer does not affect your chances of having developing cervical cancer. So it is very rarely hereditary. Okay, it is not hereditary. And how do you diagnose it? So for this I told you it is clinical and supplemented by biopsy and imaging. Clinical, what all symptoms? It will be postcoital bleeding, intermenstrual bleeding, postmenopausal bleeding. You can see the growth.
Okay.
Then this is the staging. Stage 1, which is confined to cervix. Stage 1A1 and 1A2. 1A is divided into stage 1 is divided into 1A and 1B, and 1A is divided into 1A1, 1A2. 1A1 is basically 1A is microscopic involvement. So you're not able to see the lesion macroscopically.
Okay.
Microscopic involvement less than 3 mm in depth, then 1A1. 3 to 5 mm it is 1A2.
Okay.
Okay, 1B is macroscopic.
Okay.
Okay, 1B1 is more than 5 mm to less than 2 centimeter involvement. 1B2 is 2 to 4 centimeter. 1B3 is more than 4 centimeter.
Okay.
Okay, 2 is if it invades beyond the cervix, beyond the uterus, but has not extended to lower third of the vagina or the pelvic wall. So it is divided into 2A and 2B. 2A is upper, if involves upper 2/3 of the vagina without parametrial involvement. 2B is if parametrium is involved.
Okay.
And 2A is further divided into 2A1 and 2A2 depending on the size. If it is less than 4 equal to 4 centimeter, 2A1, more than 4 centimeter, 2A2.
Okay.
Then stage 3, if it involves lower third of the vagina but does not extend to the pelvic side wall, that is 3A. If it extends to the pelvic side wall or if it causes hydronephrosis or non-functioning kidney, it is 3B. 3C is if it is lymph nodes involvement. Pelvic lymph node is 3C1, para-aortic is 3C2. 4A is adjacent organs, 4B is distant organs.
Distant organ.
Adjacent includes this bladder or rectum.
Okay.
Then staging, allowing the use of any imaging modality and or pathological findings for allocating the stage. The final stage is to be assigned after receiving all reports. The method of recording the size and assigning the stage should be noted. And what is the best imaging modality that you will do to assess the size of the lesion and parametrium involvement and bladder rectum involvement? It is MRI.
Okay.
Okay. In stages 1 through 3, allowing assessment of retroperitoneal lymph nodes by imaging and or pathological findings, and if deemed metastatic, the case is distant as stage 3C.
Okay.
Lymph node status, you do imaging, FNAC or biopsy. For assessing the lymph node status, you can either do imaging, FNAC, or you can do the biopsy of the lymph nodes.
Okay.
And for distant metastasis, you do PET scan. It has a sensitivity of 100%, specificity of 99%.
Okay.
Due to the limitations of clinical staging, many cancer centers are using MRI for the staging.
Okay.
Then how do you manage? This is again a stage-wise treatment. If it is stage 1A1, then you just do conization or leave. No need
Okay.
to remove the lymph nodes. Now once you have done this conization and leave, and then you have sent it for evaluation, if you find the margins are clear, then you need not give any further treatment. If the margins are involved, then again do a local excision or you do a simple hysterectomy. And
Okay.
if the patient has completed family, then you can directly do hysterectomy, simple hysterectomy. Okay.
Okay. And this is different from screening.
Obviously, this is the management of cancer. Now, screening
Okay.
is diagnosis.
Okay.
Okay. Then stage 1A2. 1A2, you do modified radical hysterectomy with pelvic lymphadenectomy.
Okay.
If the patient doesn't want to like completed family. If the patient has not completed family and wants fertility, then you either do conization or you do radical trachelectomy with pelvic lymph node removal.
Okay.
Stage 1B1, you do radical hysterectomy with pelvic lymphadenectomy. And if stage 1B1, if she wants fertility, you can do only up to 2 centimeter radical hysterectomy, radical trachelectomy with pelvic lymphadenectomy. So fertility preservation can only be done in stage 1B1, which is less than 2 centimeter. Okay, beyond that you cannot do.
Okay.
Okay, just a second. Just give me
So,
1 minute.
yes.
So only up to stage 1B1 up to 2 centimeter you can do.
1 is more than 4.
1B2 is, this has also recently changed. Initially it was only 1B1, 1B2. So
Okay.
now they have divided into 1B1, 1B2, 1B3.
Okay.
Okay. So only up to 1B1 you can do fertility preservation. Beyond that you can only do stage specific treatment, and you cannot allow for fertility preservation.
Okay.
Then 1B2 to 4A treatment is chemoradiotherapy. Okay.
Okay.
If it is 1B2, 2A1 less than 4 centimeter, then you do radical hysterectomy with pelvic lymph node dissection only in young patients. If the patient is which is an option in young patient, and if the stage is 4A with localized disease, then you do pelvic accentration.
Okay.
Okay. 4B, you only do palliative treatment, palliative radiotherapy for local management of the symptoms.
Okay.
And adjuvant, after you have done a radical hysterectomy, how do you decide what adjuvant therapy you have to give? Okay. So if it is high risk, what is high risk? If the margins are positive, hysterectomy you have done and the margins have come out to be positive, or if there is lymph node metastasis or parametrium involvement, then in those cases, even after radical hysterectomy, you are doing in these cases 1B2, 2A1, less than
Okay.
centimeter. Okay. So, in these cases, if all these things are there, positive margins, lymph node metastasis, parametrial involvement, then you give post-op radiotherapy and chemotherapy to the patient.
Okay.
Intermediate risk is if any of the two of three factors, that is tumor size more than 4 centimeter, lymphovascular space invasion or deep stromal invasion is there. Again, you give post-op radiotherapy. Here chemotherapy is not required. High risk, you are giving chemotherapy.
Okay.
And if none of these risk factors are there, then you need not give any further treatment. You just follow up.
Okay.
And palliative radiotherapy, advanced incurable disease for vaginal bleed, bone pain, brain metastasis, all that you give palliative. So that is stage 4B, distant metastasis.
Okay.
Okay. And what chemotherapy do you use? You usually give cisplatin monotherapy for the cervical cancer. For endometrial ovarian cancer, I told carboplatin and paclitaxel. For this, cisplatin monotherapy.
Okay. This variation is 4B.
Yeah, 4B.
Okay.
Okay. Now this is also sometimes asked, what is the survival rate? So overall survival for cervical cancer, 1 year is 80%, 5 year is 60%.
Okay.
Okay, stage wise, if you see, for stage 1 it is 96%, stage 4 it is 50%.
Okay.
5 year survival, stage 1 is 88% and stage 4 is only 15%.
Okay.
Okay, and for endometrial cancer, 90% is 1 year and 76% is 5 year. So in all these cases, you see the worst prognosis is for the ovarian cancer with the least 1 year and 5 year survival.
This 1 year, 5 year means
At the end of 1 year, once the
okay.
patient has been diagnosed, how many patients will
And
survive
the
1 year?
period of 5 years.
Yeah. Okay. For
Okay.
endometrial cancer, stage 4, 1 year survival is 47% and 5 year is 15%. So this is same like cervical almost,
Okay.
and this one is almost similar only for cervical and endometrial cancer. So it's approximately 95% 5 year survival. Endometrial, so it is 99% 1 year survival. Okay. Sometimes they ask, you have to have a rough idea about these percentages. They will not ask a particular figure, they'll give you a range. So approximately you should have in mind how much it would be.
Okay.
Sometimes they ask.
Okay.
So this was all about cancer cervix. Hope you found it useful. Thank you so much for watching.